So we're going to switch gears for our last presentation of the morning and have a panel discussion with 3 of the primary care providers who have actually been working on the implementation of the toolkit that Dr. Alving talked about. So you can hear from the real world. And so I want to introduce Joseph Herrera, who is the Director of Outreach and Education for our Rancho USC California Alzheimer's Disease Center here, and social worker on our team, cultural bilingual person who keeps us on our mark in dealing with the diverse population we care for here. And he's also been working with us on this implementation project across 3 sites, and I'm going to let him introduce the panelists.
Testing. Good morning. How's everyone doing? Are you learning any new information that you didn't have before?
Okay.
That's great, right? So if you learn at least 1 or 2 things about every presentation, you're way ahead of the game of most people, at least here in California. Can't speak for anybody else. So I have the distinct pleasure of moderating the panel, and you will hear, as Dr. Alving mentioned, she described a toolkit, and now we're going to talk to people who are actually implementing the toolkit in their practice and what they have had to do to adjust their practice and figure out how to fit this into their 15, 20-minute assessment. Dr. Sahar, please. Dr. Tokumitsu.
Good morning.
And Dr. Sigala. Welcome to my set. Now I feel like I'm in the middle of a talk.
You're welcome to remove your mask so we can hear you.
Okay. Thank you.
Good. So let's talk about yourselves first. So if you could introduce yourselves.
Can you guys hear me? Yes. Okay, perfect. My name is Sahar Soleymani. I'm internal medicine trained. I work at all of you UCLA Medical Center. I'm the medical director of our adult primary care clinic. We have about 18 providers, mostly MDs. We have some NPs. We have over 70 residents. We take care of about 20,000 impaneled patients, majority of which are the underserved population in the San Fernando Valley. With many medical problems, diabetes, heart disease, depression, a lot of psychosocial barriers. So that's us. Thank you.
Good morning. My name is Sayaka Tokumitsu. I'm family medicine trained, and I did a fellowship in geriatric medicine. I'm also one of the core faculty at the Charles R. Drew University Family Medicine Residency Program. And all of our residents operate out of the Martin Luther King Jr. Outpatient Center in South LA. And so we serve SPA 6, Service Planning Area 6, as well as Service Planning Area 8 in LA County through the Department of Health Services. So we're part of the ambulatory care network. And like Dr. Soleymani, our patients are very multimorbid. Our population is unfortunately, the rates of living under the federal poverty line are very high. Education is very limited, and the rates of illiteracy in our patient population are unfortunately high. And there are a lot of psychosocial factors that really challenge our patients and their families and their ability to care for each other, as well as cope with difficult diagnoses such as dementia and cognitive impairment. And so essentially my role in the residency program is as the geriatric medicine lead. And so most of my time is spent in primary care, but also in addressing some of the geriatric needs of our patient population.
My name is Teresa Sigala. I am internal medicine trained, and I work at UCSF Fresno. And the type of work that I do is two-pronged. The first part is I am a practitioner in faculty clinic. And so basically, we see patients from just all types of walks of life. Commercial insurance, we also see a lot of Medicare patients as well. And the second part of what I do is I'm a faculty member with the UCSF Internal Medicine Residency Program. And so a good amount of my time is spent with residents in resident clinic, and we see a more diverse population. A lot of indigent population, Spanish-speaking population, population that is very mobile, and it offers a good array of challenges. That's basically, in a nutshell, what I do.
Thank you. Alrighty, so what has, if you can tell me a little bit about your experience incorporating the toolkit into your practice. What have been the successes, challenges, or wishful thinking that you have about the toolkit in or time or anything else?
Go. Okay. So we, how I or our hospital got involved with this was as part of this research grant implementing this toolkit in primary care. We initially started talking about and implementing this toolkit before the pandemic. Cecilia and Lucia, they came to our hospital. We started talking about it and incorporating it into primary care. And unfortunately, we hit COVID and multiple surges. We're already kind of an understaffed clinic. And with COVID in the past 2 years, I mean, we've had many staff nurses being pulled into the inpatient unit. So it took us a while to kind of really get this going in our primary care clinic. And the good thing with that was that with this research grant, they actually came funding. So we've had, which have been very valuable. And I will talk about how we've been kind of utilizing some of this funding. But even having the funding, we didn't have even the time to spend it and use it to implement this. So that has been definitely some of the barriers. But what I can say, at least in the past 6 months to a year, we've been able to use it more. So that's the first thing. And really, as you guys have seen through the toolkit, it's, and with us in primary care, I mean, one of the barriers in even doing that is the time. And so really adding that to the primary care workload is really something that that really needs to be paid attention to, and how we implement that. And so from the get-go, we knew that there would be no way for us in primary care to be able to do this in primary care if we don't have the adequate support. And really, as I mentioned, our staff that we had were not and are still not available to take that role. And so we had to kind of look elsewhere, and with this funding, how we can utilize this in primary care. And what we have developed and what has really helped us is utilizing mainly Norma, who's actually one of the people here. She is one of our research coordinators. And the advantage of having her as part of our team is that she actually already trained with our medical record system at Olive View. She has patient experience. She already kind of worked in one of our dementia clinics. I mean, it's been a great advantage of having that as part of our team. And she, for the most part, up until recently, she's been kind of that sole person who's been helping us with this project. And so that's one part of it. And then the other part is that, so then how are we kind of doing this assessment is that for the most part, most cases, we're playing catch up. So it's like, I know this talk today has been about early detection, but we're really at this time playing catch up in evaluating the patients who are themselves or family members bringing up complaint about, memory impairment or memory issues. So That's the one other piece of point that I wanted to kind of emphasize on, that those are the majority of patients that we have been addressing and evaluating. And again, when patients bring up those complaints, there's no, historically what we at primary care have been doing is, okay, you have a memory complaint, okay, let's do a MOCA, let's do some labs, let's refer to neurology. I mean, that's what historically was being done at our campus, but now with having this toolkit, what we're kind of implementing is Norma, and now some of our additional support system. Erica, who's one of the other members, staff members that are helping us with this, is they get referrals from the providers, and then they will do kind of that first load of questionnaire from the patients, because otherwise, I mean, it's a huge questionnaire that we obviously have to ask patients. And so that's how we have implemented that at all of you, is that first, that pre-visit questions that is in a research phase right now is what Norma and Erica will ask patients, and then that report gets sent to our providers, who will then review and do the full evaluation. So maybe I'll stop there, and then I'll kind of add on some of our other additional workflows. So just kind of that's how we've been using it as part of the workflow, and then I can talk more about kind of some of the barriers and advantages and disadvantages.
So at Martin Luther King Outpatient Center, we're a fairly new site to the study. And so we're pretty much in our infancy in terms of the stage that we're at. But in trying to implement the toolkit, we first had to identify patients that would be appropriate to screen for cognitive assessments. And so we have something in place in our clinic through Medi-Cal called the Staying Healthy Assessment, and that's the tool that we use to try to identify people who have some chief complaint of cognitive impairment. There's a question 20 that asks if there's trouble remembering things. And so the first kind of hurdle that we've had to overcome is essentially trying to streamline a process in which everyone is getting the Staying Healthy Assessment, and that they're getting the appropriate form. There's an adult form and there's a senior form. And then trying to also operationalize how do we then make sure that our clinicians are actually reviewing the results of the Staying Healthy Assessment. So we have both a paper form and an electronic version of the form. And nursing kind of has depending on the nurse, there is a differing kind of level of comfort with using either the paper or the electronic form. Before that, as I had mentioned, there's a high illiteracy rate in the population that we serve. And so, performing the Staying Healthy Assessment in and of itself is a challenge, because if they're not able to read or understand the questions that are being asked of them, there's a lot of difficulty in filling out that questionnaire. And so it's very time intensive for our nurses. So I found just in the early stages of trying to implement this toolkit, there were some challenges in even trying to figure out a workflow for nursing that they would be able to apply the time that is necessary to even implement the Staying Healthy Assessment. So, we've kind of, we're kind of a one-man operation, and I'm it, at Martin Luther King Outpatient Center. And so essentially, I've really taken this on as a passion project. We don't have a lot of supporting staff. We very briefly had someone, Maria Elena, who was helping us with calling patients that were identified with the Staying Healthy Assessment as answering yes to question 20. And there are lots of steps before that, right, where I was going through charts on days that I was precepting and supervising residents, for example, and trying to systematically go through patients who were 65 or older and looking, and as Dr. Borston had mentioned, like really just diving into the EMR and searching for the Staying Healthy Assessment form, just to identify patients who could use a screening tool. And then, we had Maria Elena call people for some period of time to go through the screening questions, that 3-question step. And then that of course triggers more questions for the patient and informant if any of those are positive. But, it's also been very difficult, and she, in her working with us, it was very validating to find that she also had difficulty identifying informants, and when informants were available, trying to get in touch with them, and really assessing their ability to provide enough detailed information that makes them a helpful informant. And that in and of itself comes with lots of challenges, right? Because there are lots of different cultural norms for how we see people in aging and what we think of as normal aging or perhaps something that's more concerning. And so really trying to tease that out and finding someone who can provide additional information with regard to how patients are doing at home has in and of itself been a challenge. And then the full cognitive assessment. So the full cognitive assessment, incorporating that into our clinic has been challenging because it is a large instrument that requires a lot of time. In order to circumvent that, I have taken it upon myself to essentially divide it up into multiple visits. And so I've taken that tool, that large smart phrase, and divided it up into 3 or 4 visits. Our family medicine residents are extremely goal-oriented, and they like to be able to say that at the end of the visit they've completed something and they've accomplished something. And so I've tried to make it a little bit more palatable by dividing it up into smaller bites rather than giving them this daunting instrument that they had to kind of divide up on their own with regard to completion of the full cognitive assessment. So we've been doing that. And I think that, some of the great advantages of being part of this study, and I'm really, really grateful that our site has been incorporated into the study and that we're able to participate, is that I think that, it has given our providers something that is tangible that they can do with their patients who come to them with memory complaints. I think prior to this, they really didn't have a whole lot of guidance in terms of what to do with patients who were cognitively impaired. And they didn't know what to do with patients that they themselves identified as people who were having difficulty with medication management and understanding of their illness, of their multiple illnesses prior to us being part of this project. So I think that it's given some sort of context that allows residents and our providers to really use to identify people with cognitive impairment. And then with regard to assessment, I think that it's also given them some structure in terms of what we think of as normal aging, what is pretty typical Alzheimer's dementia, and what really, justifies a referral. And, I think that will likely need some refinement moving forward because of our patient population and how complex their social circumstances are. And there's a lot of difficulty, especially with language non-concordance. Our providers are not all native Spanish speakers. Many of our patients are. Many of our patients speak Spanish that is more regional to where they come from, and so it's not universal. And again, because of the limited educational background of many of our patients, sometimes even the Spanish translation needs to be simplified further in order for us to really get the information in detail that is needed. And so I think that this really is a great toolkit to really help us contextualize some of the things that we're seeing in primary care and giving us tools to move forward. I think that, some of the things that make this really rewarding is I had a couple of residents already since I started. So I started on as faculty at Martin Luther King in November of last year. And many of our residents have already said to me, well, Dr. T, before you came, we didn't have a lot of patients that had memory complaints. And then all of a sudden, I'm really seeing it's like a common occurrence. Where did they all come from? And, it's been really fun for me to say, well, they've always been here. And they will always be here. And so I think that it really speaks to the fact that the toolkit has really highlighted some capacity that was really untapped in the providers that we're training. And so I'm really looking forward to continuing this journey.
Thank you.
Well, the way I have integrated the toolkit in my practice is that in the first step, patients are identified. A lot of times they will be identified because family members will have a complaint that their family member has a problem with their memory. Sometimes patients will themselves come out and say that they're having difficulty remembering names, getting lost in familiar places, that type of thing. The other source of patients in the practice is patients are identified once they go through the Medicare annual wellness visit. And so this is something that not a lot of practices use, but it is a really good way to actually get to know the patient and identify different problems, problems with cognition, problems with behavior, problems with different motor function issues that can kind of give you a clue that something is going on and that they need to be evaluated further. And so what happens once the patients are identified is that they actually come and have a visit with me. If they're not my patients, a lot of times other physicians in my practice will let me know that there's a certain patient that they would like me to do initial questioning on, maybe sometimes a full assessment. So the way that I have incorporated it is it's broken down into several visits because it's really kind of cumbersome to try to accomplish it just in one visit. So what I tend to do is I see the patient, and most definitely it's not time efficient to have the patient come in by themselves. You definitely need an informant. And so staff will really emphasize that when they are confirming the appointment that the person needs to bring along an informant. And it has to be somebody that has really close knowledge of the patient, somebody that spends a lot of time with them day to day, which can sometimes be challenging because the patients will really be on their own for the vast majority of time. A lot of times children or other people will look in on them from time to time to come and do their medications, take them to the store. So we make sure that the informant is with the patient for the visit. And the informant does what we call the pre-visit questionnaire. And so basically it is a set of questions that I actually like to send the informant home with this set of questions, or we'll mail it out ahead of time before the appointment. And it's just a set of questions that is very helpful in identifying issues with memory, behavior, any problems with motor functioning, any problems with language, problems coming up with words. And so the second visit usually is the patient and the informant come in. I take a look at the pre-visit questionnaire and then go into a more intense assessment using the toolkit as a guideline. And so the toolkit has been a real game changer because initially, the way we were trained is you see patients that have a memory problem, or they're brought to your attention because they have a memory issue, and you do something, you pull out the mini mental status exam, and you go through it, and you're kind of, okay, well, what do I do now? So the toolkit really gives you a better idea of the questions you need to be asking, and it also really helps to have this information ahead of time, and then you go through a more intense evaluation. In the practice, I definitely will do a full neurologic exam, actually review some, lab work that we have ordered, and then usually we'll do another cognitive assessment, which oftentimes will be a MOCA. Sometimes if, time is short or for other reasons, we may do something more, more simple than that. And then we usually have a discussion about the possible diagnosis. Actually, I was really surprised once I started using the toolkit to see that there are quite a number of patients that had other difficulties because there were a lot of other things going on, such as depression, such as sleep apnea. And, with life being so complicated, it's really difficult sometimes to tease those types of things apart. So it's really helped in being able to kind of focus and, come to some sort of assessment and to be able to weed out patients that really need to be referred on. Patients that have atypical presentations, different types of behavioral issues that really are not consistent with Alzheimer's, and then other patients that have issues such as depression, sleep apnea, that need to come back and be reevaluated. And so the challenges come with kind of coordinating these types of visits. And that's one part. In the resident clinic, the problem is that you don't have very long to do your visit. And oftentimes you will get started with one resident, but they won't be back in the clinic for a couple of months. So then you'll have a different resident with the same patient, and it's really cumbersome. So I think that, maybe something else has to be developed in terms of, tailoring the process to that particular type of resident clinic.
Yeah.
To the setting. Yes, go ahead.
Sorry, what I wanted to mention, I think great points, and I think there are a lot of similarities and across health settings. The one thing I wanted to mention is that even though we are a resident clinic, we have not actually started implementing this in our resident clinic. So what we decided was to really start with our non-teaching providers, attendings, and NPs, really figure out what we need to do for them. Those are half of our patients are being seen by the non-teaching providers, and then half of them are seen by the teaching providers. So that's kind of one thing I wanted to mention, since I did not mention that. The other thing I did want to mention was regarding the comment about, kind of seeing a lot of patients like since the last year. I wanted to kind of comment on that. I was at Olive View from, 2014 until 2020. I had the same panel of patients. And yes, I was coming across, memory complaints here and there. But in the last year or so, what I am seeing and what we are seeing in our clinics is just a huge increase of complaints. As I mentioned, we haven't even had time to really do our screenings, and just recently we have started doing that. And a lot of the cases that we are evaluating right now are coming from patients kind of complaining that. And I think, there were a couple of talks earlier about COVID-19, about social isolation, and I think really, I am, seeing this at Olive View. yes, I completely agree with the residents. It's just like the number of complaints have dramatically increased. So I really wanted to kind of comment on that, and I think it really ties some of the earlier talks in this as well. So with that said, I mean, I think that some of the other things, just wanted to kind of follow up on some of the things that we are currently doing, and some of the barriers is, yes, I mean, even though we have Norma and we have Erica, we have one of our social workers that, again, are helping us with gathering those first information. I mean, I think that disadvantages, as mentioned, and I wanted to reemphasize, are really kind of catching patients and informants. We have a very hard time, getting informants with our patient population. So, I mean, I think that, that's across all of us. And then the language barriers, and we have two, Spanish speaking, which are majority of our patients, but really kind of getting that information in even non-English or non-Spanish patients are really, really challenging for us. And then they even help us. I mean, Norma and our social worker, they help us with doing the cognitive testing as well. So, I mean, we're not even the ones doing that. But what I want to mention, even despite that help, for us as providers to then go through the toolkit, do the evaluation is really time consuming. I mean, it is really taking those multiple visits to complete that and get the, review those questions, review the cognitive testing. So definitely a lot of barriers to that. And I think the second barrier, and I think one of the advantages of having this research money, is that we have been able to implement faculty talks. We have a monthly faculty meeting that Cecilia helps us, Freddie, Dr. Rosen. I mean, they all kind of come in. Providers, provide their cases. We'll review cases. It's like really using it as a teaching point. I mean, one of our conferences was like going through cognitive testing. We realized that most of the time we weren't even using the correct cognitive testing that needed to be done. And I mean, especially for our population with Spanish speaking or low education level, like we were using NOCA, which we have learned and we've taught our providers that is not the correct, cognitive testing to use. So, I mean, I think a lot of it is just the time that takes to educate, us as primary care providers to be able to use this. I mean, we have, faculty talks on diabetes and other things. So, I mean, I think really incorporating it, and this grant money has allowed us to incentivize providers to learn more and participate in these things. So those are definitely some of the advantage of participating in this research study. Yeah.
Thank you. So, given that all of you have mentioned that you work with multiple populations or diverse populations, and talked a little bit about the challenges in working with them, can you each highlight and this question comes from our viewers, our attendees, one of our attendees via Zoom. Can you please address any challenges with early detection in the immigrant cultures?
Yeah, well, I mean, as I mentioned earlier, I think that there are different cultural norms for what is considered normal or abnormal aging. And I think so, depending on the level of awareness of family members or partners, in terms of what sort of symptoms could be a little bit more concerning, I think that definitely influences their bringing up the question, like, is this normal or isn't it? Or do you think that they need a memory evaluation? I find that even folks who do complete the Staying Healthy assessment and answer yes to question 20, they wait years before saying yes to that question. And so there's a lot of I think, uncertainty, maybe a different level of awareness in the community that really triggers folks to say, maybe there's something that could be explored a little bit more in detail. And maybe this is something that's worth bringing up to my provider. And then there's the issue of having to gain access to a provider, any provider, whether it be primary care or a specialist. And so once they get in, you know, in our clinic, we have unfortunately a very long wait for your initial health assessment once you've been in panel to our clinic. And so once they've come in and there's just been this accumulation of comorbidities and things that they want to address, sometimes memory or cognition is not the thing that's at the forefront of their minds to bring up to a provider. And so I think in that sense, you know, there's a lot of value in having something in place to remind people, like, are these things going on in your home? Are you having trouble with remembering things? Have you had more car accidents in the last couple of years? These are, I think, tools that are really put in place to help give us a well-rounded idea of what's going on in people's lives. We only see them for such a small percentage of their lives. And so I think in dealing with and in serving a community that is so diverse with a large immigrant population, it's really trying to understand, like, what are those cultural norms in aging? You know, is it concerning to them that mom is not making the pozole the same way that she used to before? Is it different that, you know, grandpa who used to help me with mathematics as a kid is now having a really hard time figuring out change at the grocery store? Like, these are things that, you know, sometimes maybe they aren't triggering them as issues with cognition. You know, maybe it's like, oh, well, you know, they're getting older, and so they just stopped doing the grocery shopping, or I've taken on this responsibility at home, but I don't really know why. I haven't correlated it to any change. I think that's been some of the challenge when we're trying to gather that history. Those subtle changes aren't things that families or informants are necessarily picking up on.
Another thing I'd like to add is that a lot of times in some of our patient populations, families are so integrated, and a lot of times families have different perceptions of what normal aging is. Okay, it's normal to do this, this, and this. But I find that a lot of times families will try to compensate for the patient's deficiencies. And so, you know, you can ask, like, well, are you having difficulty finding your way, you know, to go to the grocery store? And, well, they always get driven to the grocery store, so that's not really an issue. Or do you have difficulty making something? And so the patients' families will compensate a lot, and then they will also really downplay the actual severity of the deficits.
Yeah. I mean, the only other comment I want to say, the staying healthy assessment, I just feel like a lot of times, yeah, as you mentioned, I think it's a lot of false negatives a lot of times that we see on those staying healthy assessment forms. And then even if we ask the question, I think it's really important who is asking the question, how they're asking the questions. So I think those are important. And I think just kind of specifically on your question about the immigrant population, I mean, I think there's just a lot of times there's just so much else that they're dealing with, and that the memory issue sometimes may not be on their top of the list of problems that they need to talk to us. And we always, you know, I go into the room, I'm like, what are the top 3 things that you need to talk about today? Because, you know, there are like 4 things I need to talk to you about. What are your things that you need to talk about? So obviously it's like they have to see, you know, what they need to prioritize. So I think. No.
And then there's a last minute, oh, by the way, doctor.
That is exactly, I mean, I feel like that is exactly what happens. By the way, I keep forgetting things. I mean, that is something that I just keep seeing in our clinics. That memory, by the way, on forgetting things is just so common right now.
Right.
Yeah.
So in interest of time, we have a few minutes left. What happens post-diagnosis?
Yeah, so I mean, I think that is exactly one of the challenges is like, okay, what do we do? And so, I mean, I think that is something else that we're trying to utilize this research money and to kind of figuring out what to do. And so what we have done, and that's what our providers want. I mean, the goal that has been set for us is like, okay, take care of these patients in our primary care, but how can we do that? And so just kind of what are, helping, help streamline the resources. So that's something that we have been trying to do. We had a talk, one of our faculty meetings, about one of the new resources in our hospital that's a dementia navigator, and which is part of another grant money. So I mean, I think we're very happy, and I think it's great. You heard it, that there is now more state funding for some of these resources. So that's definitely something that we need, and more of it, to be able to take care of these patients in our primary care clinic. So the dementia navigator, and what we've done as part of other things in our with this research money is to buy stuff that we can provide to our patients. Hearing aids. Our patients, we refer them to audiology. They don't get a hearing aid for years. They may not even qualify for a hearing aid. But what we've done is use some of the money that we have to buy at least those voice amplifiers that we can give to patients, or puzzles that we can, memory puzzles that, we've kind of developed into this care package that we kind of give some of our patients that we are kind of assessing. And so the next step of that, what we're actively working on, is, again, how to give that tool to our providers to do that next step, that once they diagnose, what to do and what resources they have at their fingertips, and who is that person that's supposed to give those resources. Because we can't. I mean, as primary care providers, with everything else that we're doing, there is just no time for us to be that person. And so if it's our social worker, Carla, we're using Norma, or our dementia navigator to help us provide the resources that the patients need once we diagnose.
Thank you.
Yeah, very similarly, our social work department is very shortly staffed. And so we just don't have a lot of resources to dedicate to our patients who have been given a diagnosis. So I'd love at some point for our clinic to have the bandwidth to have a dementia care navigator. I think that would be extremely helpful. Right now, it's really difficult. We put together, I've used the community resources packet that you, Joseph, were kind enough to share with me. I've added a couple of things that, in my experience, have helped my patients and their families with regard to kind of free resources that are available in the community, including caregiver training videos that are available on YouTube for free. So things like that we've tried to really implement, and I think that just in our participation in the study, I think it's really highlighted some of the gaps that exist in our community with regard to community resources, and how fragmented resources are in terms of how we can really support families that are dealing with the challenge of having loved ones with cognitive impairment.
Thank you.
I think in our practice, the difficulty in the residency clinic is that we don't have social workers in our clinic. And so we can refer someone to social work, but it's not something that you really expect to happen or to really get any feedback on. And so that's really one of the challenges. One of the other things that we need to get better about is actually teaching residents how to really care for patients that have Alzheimer's. A lot of times, it's, well, what do we do? So I think we can use more direction and more instruction. And so basically in my practice, what I do is, let the patients know about community resources, which unfortunately are not huge. I think in the future, really a lot of attention needs to be paid to how to train caregivers in how to take care of patients with Alzheimer's. And then also there needs to be federal and state funding in actually developing resources for patients that actually need placement, because it is too expensive. And so, what the residential care for the elderly program offers is not enough to actually get the patient good care, in a facility. What they end up doing oftentimes is going to skilled nursing, which, obviously is not optimal.
Right.
I'd just like to add that, the other kind of post-diagnosis elephant in the room is advanced care planning, right? And so how are we training our residents? And I think that our participation in the toolkit study has really also spearheaded my efforts to train our clinicians with regard to how to approach advanced care planning, and really making that a like a staged conversation that happens with patients and their families, and making sure that the conversation doesn't just end with, okay, now you have dementia, and now we have to deal with all of these behaviors or all of these other manifestations of the illness, but it really, kind of maximizing the time that you have with loved ones while they still have capacity. How are we really, optimizing that time to plan for the future? And so that's been the other, passion project that has come up from our participation in the study, is really, making sure that we're not ignoring that elephant, that we're really bringing it to the forefront, and empowering families and patients to really have their voices be reflected in their planning.
Thank you very much. I wish we had more time, because this is very engaging and very educational. And we can see how we have touched pretty much every conversation, every presentation since the first one this morning. And there's a lot more work to be done. But thank you very much. I really appreciate your insight into how the toolkit has been working for you, or how you've been making the toolkit work for you. Thank you very much.
Thank you. Thank you.
Any questions before we go to break?
Okay. Thank you. This is kind of an ugly topic to bring up, but I have to do it. It has to do with medicalization, and I know everybody in the room understands what medicalization is. It's forcing a human experience into a medical diagnosis, and I think we spend a lot of time on that now because dementia is a big problem, and one way to start is by medicalizing the problem in the way that we do. But a brief experience that I'll cite from my time working with immigrant communities in Seattle years ago was that if you build it, they will come. And that's not the memory clinic, because they didn't come there. They would let us go to them in their homes if they were in need of services, and those services required that they got a diagnosis. And so it's really the building of the service sector, which is a collaborative enterprise with the communities that we're talking about. And there's nothing more to say. I know you all know this, but I wanted to just get it on the table to percolate around as we interact with all these experiences.
Thank you. Thank you.
Well, thank you very much.
Thank you so much for your time.